Hey, good morning, everyone. If you can hear me, go ahead and post something in the chat there. Just let me know if you guys can hear me or not. Which perhaps you can't, but we'll see. Perfect. And we'll get started in just a few minutes here. All right. Good morning, all of you. And of course, this is our last session for the summer, so if you have any last questions you want to ask, make sure to get them in there now. It's good morning. Can anyone remind me if this is where we left off last time on this slide set? I think we were on the pharmacogenetics. Oh, Josh. BF, does that mean before? Boyfriend? Not sure. Maybe Kat was walking on her keyboard, who could say? Amina? Hey, good morning, everyone. We just definitely boyfriend. Well, I don't think we're going to have any talk of those here. They don't really have a whole lot to do with drugs, usually. Unless they're the really bad kind, I suppose. Yeah, but if anyone can remind me what slide we were on, let me know. Good morning to everyone. I hope your semester's off to a pretty good end here. You guys will enjoy a nice break after finals and all that. No one recalls what slide we got to? $27. That's it? Oh, yep. Okay, that's fine. I'll do that. So we mentioned some of the common ones. Well, I'll start at 27. Because Kadeen said so I think that sounds like a good one. And most of the way through your guys' drug information assignments, got a few more of those to grade, and then I'll work on the prescription assignments. Yes, good morning. All right, well, it's 8 o'clock. I'm gonna go ahead and get started here. Start recording. I did want to make mention of one thing. I was looking through the drug information assignments. Most of them have been pretty good for the most part. One thing I want to mention is that I want to make sure you understand the difference between a pharmacokinetic drug interaction and a pharmacodynamic interaction, right? And sometimes they can be difficult to discern the difference. So with a pharmacokinetic interaction, there's something changing in terms of like the distribution of a drug, or there is a change in the metabolism, which was on our assignment, change in bioavailability, change in excretion, something related to that, right? As opposed to a pharmacodynamic interaction, drugs may either potentiate the effects of one another or they may antagonize the effects of one another, right? So let's say, for instance, we're dealing with the drug diltiazem. That's a good example. So diltiazem is a drug we typically use for like tachyarrhythmias. We can use it for hypertension. It's also a fairly strong CYP3A4 inhibitor itself, right? So if I were to put that drug with another antihypertensive drug that was metabolized through CYP3A4, and diltiazem inhibited the metabolism of that drug, making it more effective and then further dropping blood pressure, that's a kinetic interaction because there's more of that drug around because diltiazem has inhibited its metabolism. Let's say, for instance, like the another calcium channel blocker, amlodipine or something. Those two interact with one another from a kinetic interaction. From a dynamic interaction standpoint, though, if you have two antihypertensives together and they work synergistically with one another, that can be another interaction, which may be beneficial in some situations, but in others, it may be detrimental to the patient. If you make them hypotensive, that's not generally going to be a good thing for the most parts. So make sure you're kind of understanding what the mechanism is between those two types of interactions, and you can see why we're changing certain things. So say, for instance, if I change the dose of a drug, like, why am I doing that? What am I trying to account for? And that'll make more sense when we get into specific drugs next semester, but I want you to have the kind of fundamental understanding now. The other thing I will mention, and this was not a problem for most people, but I did notice more than one, were copying things directly from sources like drugs.com and then putting that into their stuff without really any notations about quoting that site. They were just kind of blatantly just copying it, and that is never appropriate for any purposes, whether it's my class or anyone else's. You cite your sources, especially if you're going to be copying something verbatim, which is quite easy to tell, especially from a public internet site. Would turn it in. Like it was very easy to determine that when it's word for word, especially when it's in such a voice where I know that you guys, being starters, being newbies, wouldn't be really talking or writing like that in the first place. So please always cite your sources. If you're going to do that, like, at least include it in your reference list. And if you don't do that, like, at least quote it, or just don't do that at all, in fact. Because it's pretty easy to find out, and it's going to make you lose credibility with your preceptors, your attendings in the future, all of that. So please make sure you're writing in your own voice. Make sure you're interpreting things for yourselves when you're doing these kinds of writings, and that will serve you well in the future. But anyway, so getting into the rest of the topic here, because we got to get through this section and then the last one here by 10 o'clock, and then we'll see where we're at. So anyway, we were talking about therapeutic drug monitoring in pretty great detail here. Remember, this is where we are using blood levels of a drug in order to help us determine, is it within a therapeutic range? How do we adjust that based off of other clinical indicators and things like that? There are some limitations to this, and we don't do it for every single type of drug. And I listed, I think, in the slide before here, some of the common ones you can see being being used for. But what are some limitations? Well, cost can be an issue, right? So you're doing an extra lab test, and depending on when that's happening, especially if you're doing a blood draw and that's the only thing you're doing, that can be more costly than if you're doing it with a bunch of other labs at the same time, potentially, because it's only one stick versus multiple. If a drug has a really wide therapeutic range, right? So it doesn't really matter if you're getting in within the range, because it's so wide. Because if it's a wide therapeutic index, then there's so little overlap between where a drug is being effective versus where it's being causing toxicity, then it doesn't really help us out, because it's pretty likely the patient will be in range on standard doses. If you don't have information on what a good therapeutic range is, so if that reference data isn't there, sometimes you may do this and get a level just to see is the patient being adherent or not, because obviously if the level is 0, then they're not taking the drug, right, for whatever reason. But if you're getting a level trying to then interpret that and there's no references out there saying like this is a therapeutic dose versus this is a toxic dose, then again you're getting information that you can't really do much with, and there's no point in getting a lab if you're not going to be able to make any decisions off of that, whether it's a drug level or any other type of lab out there. And then again, if it's a direct response measure kind of drug, so if I'm giving an antihypertensive and I can just measure your blood pressure, that's going to be much easier than getting a level of the drug itself, right? Usually we want for things like where you can't get like a really direct response measurement, like seizures, for instance. Like I can treat a patient with an anti-epileptic drug and they cannot have a seizure for a month, and I don't really know if it's because the drug is working or because they wouldn't have had a seizure in the first place. And so by using those drug levels and being able to determine if they're at least in range, that gives me some decent idea that at least the drug should be effective if that is what is truly preventing those seizures. So what are some reasons that people will get levels inappropriately? There are many that are out there, and I see this as a common mistake for a lot of new providers and even seasoned providers, as the case may be. So if you're getting labs routinely or too often just because it makes you feel better, that is not a good reason, right? You're trying to make the patient feel better and not yourself. And so getting labs just because you just want to be sure, even though there's no clinical reason why the patient would have changed, then that's not really a good option, or that's not really a good reason to do that. If a patient's responding appropriately and there's really been no reason why the level would have gone up or down appreciably because the kinetics for the patient hasn't really changed as far as you can tell, then again, there's no real point getting that level in those cases there. And again, when there's no apparent change in patient-specific kinetics, right? So if there's no reason their clearance would have changed because their serum creatinine has been rock steady for the past couple weeks, then there's no reason why that drug level should have necessarily changed, depending on the situation. And then getting samples at incorrect times, right? You have to know, and we'll learn about this in the specific drugs, like am I getting a peak level? Am I looking for a trough level? Am I just getting a random level? This is going to be dependent on the type of drug we're dealing with. It's going to be dependent on a lot of factors there. So you want to know what type of sample you need and making sure you're timing that appropriately. I've seen instances where nurses will get a level. We're supposed to be getting a trough level, which the trough is, again, that lowest concentration right before the next dose. We're trying to get that, and then the nurse will give a dose and then get the level because she didn't know that it was supposed to be a trough. And then at that point, the level looks like it's extremely high. And then you think, okay, well, wow, the patient's not clearing it. I must obviously need to change my dose. When really you just could look at the timing and realize, hey, there's actually no issue here whatsoever. We just have to do another level at the next trough, which is not great. So what are the benefits here? So there are several, and so when you compare it to patients who just got standard doses and didn't really have any therapeutic drug monitoring, you find that you reduce the number of people who develop toxicity, and again, this is going to be also leading to more patients being within that therapeutic range for longer, right? So they're getting in that Goldilocks spot where they're therapeutic and hopefully avoiding where they're going to be toxic. And that leads to a number of other benefits too. So not only is the drug more effective, but we're also going to see things like decreased length of stay. And so, for instance, if you can get a patient's infection cleared faster, that means you can get them better and discharged sooner rather than trying to kind of chase around why is the patient not responding, then you change drugs and all that. If you could just do TDM in the first place, that helps to prevent that. And overall, it tends to be cost effective because of this. So what are the steps we're going to do here? So one, we want to figure out if we're doing sort of a routine monitoring or a specific indication. For instance, have we changed the dose recently? We want to see if they're in range. Or is the patient having a lack of response? If they're taking an antibiotic and you're giving it to them and their fever's still up and their white count's still up and they're not really responding, that could be a reason to check a level. And then we get the blood sample done, right? So you order it. The nurse collects it, for instance, if you're in the hospital setting or if they go to Quest or wherever they go. Do they get it at the right time? So if it's a peak level, do they get it right after a dose? If it's a trough level, do they get it right beforehand? If it doesn't really matter, then you don't have to worry about that. But did they use the right collection tube? And so you may learn this at a later date when you get more into laboratory testing and things like that. But different tubes may have different components within them, and that may actually screw up your levels. So for instance, we use the drug lithium for patients with bipolar disorder. Well, certain collection tubes actually have lithium in them. They're called a lithiated tube. And if I were to try to measure a lithium level off of that, it's going to look elevated, right? Because of extra lithium there. Some tubes contain the product heparin, and heparin's an anticoagulant. So if I'm measuring someone's clotting factors or measuring their ability to clot, that's going to screw it up too, right? And then, you get the laboratory measurements back, and then they have to communicate those results. So the lab will communicate it back to you. This is where knowing your units can be really important. This is why I stress trying to include these whenever you can when you're reporting things out, because if you're not talking about the same units and those same therapeutic ranges, it won't make a whole lot of sense. And so a good example of this would be like if I'm taking call for the poison center and they call me up and they have someone who's experiencing an aspirin overdose. And so a lot of that we base off of the levels that we measure for that patient there. So for instance, 15 to 30 milligrams per deciliter is considered a therapeutic range. Once they get up into the 40s, they start to become symptomatic. If they get up to a level of 100 milligrams per deciliter, they are at very large risk for seizures and, respiratory failure and death, right? Well, I was talking to a provider, and they were measuring, or they were telling me the patient's aspirin level, and they said it's 400. And I go, oh wow, like is the patient dead? Like what's that? That doesn't sound right. Like how are they? And they go, no, they're just they're a little tachypnic and a little febrile, but other than that, they seem okay. And I go, my goodness, well, level 400 should be fatal. So what's going on here? And so I say, well, what's the units on that? And they go, oh, it's micrograms per ml. I said, okay, well, that makes a lot more sense. And so when you convert that mics per ml over to milligrams per deciliter, guess what? It turns into like a level 40, which is concerning, but not nearly as concerning as a level of 400. So this is where making sure that you're looking at the right units can mean a whole lot of difference, because again, how concerned I was for that patient, what my management plan for them was far different at a level 40 versus a level 400, which probably just would have required a chaplain consult at that point. But then once you get that level back and you think it's accurate, then you're going to take the clinical picture into account. You never want to just go ahead and make a change in therapy based off of a level in isolation, right? You want to take into account, how's the patient doing? How are they looking? How are their other lab values tracking and trending along with this drug level? And then once you do that, then you can optimize the drug treatment. So you either can modify the dose, you can modify the interval, right? Because those are the only two things that we really control, or you may do both at the same time. I'll tell you generally it's going to be one or the other. You tend to over or undershoot things if you try to go and monkey with both at the same time, unless the levels are really, really out of range there. So, and then you rinse and repeat, right? So you then wait for the patient to get to a new steady state, and then you go ahead and do that again, right? And so I actually had an instance of this just working this week where we were modifying, we had a patient who was receiving the drug vancomycin for an infection, and they were shooting for a trough level of between 10 and 15 micrograms per ml. And then the patient came back with a level that was like 17 and a half, and it looked like an actual trough level there. And I was talking with the provider, and I said, okay, well, we can go ahead and modify the dose. We ended up decreasing by about 10% or so. And I said, well, I noticed you got a level, you got another trough ordered for the next dose. And they're like, oh yeah. And I go, well, that's way too early. It's, you're usually requires 3 to 4 doses before we get to steady state. If you check it, it's going to be too early, and it may not have really reached that new equilibrium. And said, okay, well, I said, well, why don't we get it before the 3rd dose? And they're like, well, this patient's really, patient's really unstable right now. Let's go and do it before the 2nd dose. I said, well, okay, but just know that level may not be totally accurate, right? So sometimes, being part of the healthcare team means sometimes you acquiesce to people because, again, they're seeing the patient, they can see them in person and know kind of what's going on. So sometimes you have to compromise, right? But you can't win every single battle. So getting to the topic of pharmacogenetics and TDM. TDM is typically pretty reactive, right? So you get a level back, it's high, it's low, and then you react off of that. Knowing the genetics of a patient may help us to be a little bit more proactive in terms of individualizing therapy. One, we can see whether a drug potentially is a bad choice for that patient. They might be a poor responder or non-responder. Or in some instances, we may be able to determine, okay, well, based off of this patient's pharmacogenetic profile, based off of how they express a certain enzyme, for instance, they may help us to determine, do they need an exceptionally high dose, a low dose, what do we need to do here? And so, for instance, if you have, patients who are sort of in a random sort of assortment here, you could start everyone off on the same starter dose of a drug, and not all of them are going to respond the same. And so by doing certain screenings, and again, as time goes on, we find better targets, and it becomes cheaper and more readily available. You can try to isolate out those patients you think would have good response to the drug, those who may have no or poor response, or those who may be at really big risk for toxicity. And so I may not choose to use that drug at all for these type of patients, or I may modify the dose in order to account for these differences in response. And so just a way for us to be more proactive in determining, basically kind of getting, instead of having to get that first level back and then, responding to that, it's able to basically start one step ahead of the game a little bit. And so, again, you may see this more commonly as time goes on. Not only that, but pharmacogenetics can help us to be more targeted in how we're going to be choosing our drug therapy. Because nowadays, a lot of times what you're doing is choosing, going with drug A, and then that doesn't really work for your patient. You go to drug B, and the patient kind of got some toxicities from that. Then you go to D, and then you go to C, and then, well, maybe I'm going to go back to D and try a different dose here. Being more sort of targeted in how we're going to do this by doing a simple diagnostic test, like seeing, do they have a particular isoenzyme of this enzyme, and then determining what drug is going to be best for them based off of that can really help you out. So going to save you time, saves you money, and hopefully helps you to prevent things like toxicities from developing for those patients there. So that's hopefully how the future is going to go. But let me walk you through an example of a case that I've had in the past of a patient who's taking digoxin. Digoxin is a medication we use frequently for patients with CHF, and also for potentially for atrial fibrillation. And so it's a cardiac med, so this is certainly one with a narrow therapeutic index. If it's too low, then perhaps the patient will have an AFib exacerbation. If it's too high, that can lead to significant arrhythmia, right? And so looking at this, we can see that a patient was on the same digoxin dose for about 15 days or so, and they're seen in the clinic, and they appear to be doing pretty well, like no obvious toxicities or anything like that. And they got a digoxin plasma concentration drawn that morning of the visit, and it was reported back at 3.4 nanograms per ml. Okay, the therapeutic range we know based off of our references is between 0.5 and 2 nanograms per ml. So already you can see this level looks too high, right? And so we want to think about, okay, well, why would it be too high? What are some reasons why you may see this elevated serum digoxin level, right? And so you have to ask a series of questions. So just like when you're trying to determine a diagnosis for a patient, you have to go into that same sort of detective mode here. And so you're asking things like, well, when was the dose last taken? When was the blood drawn in correlation with that, right? Was it too soon? Was it too late? What about the dosing regimen? Had there been any changes? Because if you're working, say, for instance, in the family practice sort of realm, maybe the cardiologist who's changing that med, and if that has not been communicated to you, then you may be working off of old information, for instance. And then are they experiencing any adverse effects? So this is where you want to really target it into digoxin specifically. The level's high, and so you want to inquire to see if there are any specific side effects that they're experiencing that may show that they have digoxin toxicity, right? So it's not always just arrhythmia that can develop, but for instance, with digoxin, there's very unique sort of side effects. Like, for instance, they get these halos around lights. They get sort of this yellowing of the vision, which is called xanthopsia, and they can experience some pretty significant nausea and vomiting with that. And so you would ask about these things specifically to make sure that patient is not developing any of those things or has experienced any of those. And so then you go back and you remember your intro to Pharm lectures many years ago, if you're working with this type of patient, and you recall that, oh yeah, okay, my steady state level, this patient's been on for 15 days or so, and so that's a pretty good time to get to steady state for digoxin. I know that it's going to be based off of the bioavailability of the drug, that's going to be based off the dose they're receiving, and then over their clearance and the dosing interval. So what's going on here that has led that level to be too elevated, okay? So in terms of bioavailability, is a patient absorbing more drug than average? Like maybe there's an interaction to where first pass metabolism has been decreased, right? Maybe there's been some sort of CYP enzyme interaction that could be affecting that. Is the patient taking more than prescribed? Like perhaps they have some memory impairment and they forgot they took their morning dose. They took a second one on accident, or maybe there's been a dosage change that you're not aware of. In terms of clearance, like has the patient's clearance changed recently? One thing you learn about digoxin is it is almost entirely renally eliminated. So then you go back and see, okay, well, what's the patient's baseline creatinine clearance? Has it changed? Has it gone up? Has it gone down? Maybe that's affecting it. And then the dosing interval. Are they taking it more frequently than prescribed, less frequently? So these are all questions you're going to be asking in order to determine which of these variables has changed in order to lead to that steady state level being too elevated. In terms of the level itself, like, could there be an assay error? Could there be something where the lab was measuring it incorrectly? Sometimes there's interfering substances that can lead to elevated levels on accident. So if there's like a drug-drug interaction or like an herbal interaction that may be cross-reacting with that assay, leading it to look higher than it should. That's a rare thing, but it could happen. So these are all the possibilities you're trying to rule out when looking and evaluating these levels here. So what do you do now, right? So you talk to the patient. They seem like they're doing fine. They say they're taking the meds like they're supposed to. There's been no dose changes. Well, one, you got to confirm the sample timing. And then you're going to be confirming when that happened in relation to when that patient's last dose was. Was it last night? Was it this morning, right before the level was done? You determine their adherence. So again, you just talk to them and hopefully they're going to be honest with you and tell you whether they're taking it like they should or not. You look for concomitant substances that may be affecting it, like drug interactions you may not be picking up on because it's not contained in their medication list. Like, are they taking an over-the-counter drug or an herbal or something like that? And then you question, well, maybe the assay was wrong. Maybe you can just repeat the sample. Oftentimes, if you get something that looks really incorrect, the best thing to do is just to go ahead and repeat the sample to see, okay, well, something wacky is going on here. Let me just repeat it and see if that's a real level or not. So we do this frequently. If, a drug level comes back and it's like 10 times higher than what you would expect it to be, we'll just like, wait a second, something's really off here. Let's go ahead and redo that. And then you're determining the bioavailability and clearance for that patient there. So you're looking at the renal clearance, you're looking at drug interactions that could be affecting this, and determining, okay, where had the changes occurred. And so the question is, what's the appropriateness of digoxin TDM for this patient here? And so we want to make sure that there is, adequate indication to do so. The timing is appropriate, and then also that we're rationally interpreting that level, right? You don't want to just take that level and just look at it in a vacuum and react to that. You have to take into account what else is going on with the patient here. So in terms of adequate indications, why would we need to do therapeutic drug monitoring for digoxin anyway? Well, one, if we're suspecting the patient's having toxicity. So if they started complaining about those halos around the lights, frequently if we're initiating a new drug that has a narrow therapeutic index, you go ahead and get a level regardless, just because you want to make sure they're getting within that range. And then if they've had any dose adjustments, so perhaps they've had some renal instability, maybe their clearance has gone down over time or something, you can go ahead and get a level for that. Or if they're just high risk, sometimes if your patients are at particular risk for developing arrhythmia or some other toxicity, you can go ahead and get a level for them for that particular reason. If you suspect there's a new drug interaction that could be affecting the level, you can go and check it then. If you suspect there's been an overdose, whether intentional or not, you can get a level for that. Changes in other bits of pharmacokinetics, or if you're deciding if you want to continue that drug. If a patient's clinical picture is not improving on a drug and you check a level and it's too low, well, that could be a reason why. But if they're within range and they're not improving, like if I had a patient who is getting seizure medications and they're within the therapeutic range for a seizure drug, but their seizures have not changed, the frequency has not, then that's probably not a good reason to continue that drug at that point. They're really a poor responder. So interpreting the drug concentration, right? So when you're actually looking at those levels, some things you want to be aware of. One is the drug at steady state. Recall that if you get a level too early, before it reaches steady state, it's going to look falsely low, right? Because again, you've not gotten that total dose stacking effect, and so it's going to appear to be low. That's not really a problem here, right? Because it was high to begin with. You want to think about things like sample timing and when that was done in conjunction with the dose being taken. adherence. So again, is the patient taking like they should? Sometimes you'll find patients who won't be adherent to their drug regimens, but if they know they're getting a level done, they'll go ahead and take a dose right beforehand just to make sure that you at least see something on there. And then correlating that time between the dose and the sample collection, as I kind of mentioned there. You want to make sure the blood sampling site is appropriate too. I've had cases to where nurses in the hospital have drawn levels off of a line that actually had the drug infusing through it, which is not a good idea because then the levels look extremely high because basically they're just measuring the drug out of that line. And so the levels can look oftentimes very wrong because of that. And then also, intrapatient variation. Not everyone's going to respond to these drugs in the exact same fashion, so you have to take that into account. So reasons why levels don't make sense, right? Because sometimes you get a level back and you're like, that just seems completely off. What's going on here? Well, one, if the wrong dose was given or the infusion rate was incorrect, that could be one reason that it is too high or too low, potentially. You think about things like you order a med from the pharmacy, and that patient gets it, and you just kind of assume that the pharmacists are doing their job and they got the right dose. But is that always the case? Not necessarily. People make mistakes all the time. There's human error in every aspect of medicine, so maybe the pharmacy screwed up, right? That's a possibility. Maybe a dose was skipped or the infusion was held, right? So the level looks way too low, and you're like, what's going on? The patient's getting their doses like they should. Well, what if they had an MRI scan for a couple hours and they had to be off of the unit and they couldn't get their drug? That could be one reason why it's too low. If the dose was given at the wrong time, but the blood drawn at the right time, or vice versa, if the drug was given at the right time, but the blood was drawn at the wrong time, this can again lead to levels being too high or too low. So you have to, again, be kind of like in detective mode and go back and inquire, because sometimes you'll find that nurses will be very diligent in their documentation and making sure that they are noting when all these times are happening effectively. Sometimes they know they kind of screwed up and they'll kind of fudge the timing a little bit too, and that's more difficult to determine. But again, we typically go off of the assumption that everyone's working in good faith here and that no one's going to be falsifying documentation. But does it happen? Sometimes, depending on who you're dealing with. Looking at things like samples taken through the administration line, I mentioned that earlier, leading to extremely high levels. Basically, they're just measuring pure drug practically. Samples taken from the wrong patient, that's happened before too, where you get a level and it's like 0, and you're like, well, I know the patient's getting the drug, what's going on here? And maybe it was another person in that same room, right? So sometimes you'll find more than one patient in a room. That can be an issue there. Sample handling issues can be important. So if a drug is either put into the wrong tube, or if it's supposed to be kept on ice and it's not, or maybe it was mislabeled or something like that, all of those can lead to reasons why levels may not make sense. So in terms of factors relating to the kinetics of the drug, well, perhaps your patient falls outside of the population average. Most of you, when looking up your drug information assignment, the dosing was based off of the assumption that your patient is an average person in terms of population kinetics, and many patients will fall outside of that, right? So we just know that's going to be the case, and so maybe your patient has. Again, samples drawn prior to steady state is another reason why levels look falsely low, and maybe a reason why levels may lead to premature dose changes, for instance, or if it's going to be drawn at the inappropriate time based on the kinetics. And so as an example, some drugs have what we call a distribution phase, and what that basically means is you can give an oral or an IV dose of the drug, and it kind of sits there in the blood supply for a while, and maybe it takes 4 or 6 hours or so before it can distribute out fully into the tissues. And so if you do that too early, then it looks like it's too high because all that blood's kind of still hanging out there in the blood before it's had time to distribute to the tissues. So other things include the wrong drug being assayed. Maybe you wanted to get gentamicin level, but they measure tobramycin, which could possibly happen. Level be 0 at that point. Sometimes labs will interfere with endogenous substances and can trip the assay and make it look too high or too low potentially. As I mentioned, storage can be a really important one from the lab standpoint. And there's even technical errors, right? You assume every lab you get back is completely correct, but even the lab makes errors too, right? So again, it can be very difficult to determine something like this unless you just pick up the phone and talk to them and say, hey, was there an error here? Was the machine screwed up? What's going on? So in terms of case resolution, one of the things that we'll learn about digoxin is it actually has about a 6 to 8 hour distribution phase. And so if you measure levels during that 6 to 8 hours after a dose, it's going to appear falsely elevated because more of that drug is sitting around there in the blood. And so we asked the patient, and basically she said, oh yeah, I took my dose about 2 hours prior to getting that actual lab done. And so you say, okay, well, that could be a reason why it's too high. So what do you do with that case there? Do you just go ahead and change the dose? Well, no, you go ahead and you can repeat that level at about 6 hours later, and it came back and it was 1.1. So now we're within range, it's between 0.5 and 2. So basically, even though we had a high level, no intervention was truly needed here. So sometimes the best therapy is to do absolutely nothing, right? You appear smart, you didn't have to expend a whole lot of effort, and then you're good to go, right? So overall, therapeutic drug monitoring, we're using the serum levels, but you got to know the caveats. Know that it doesn't apply to every single drug out there, and it's helping us to try to optimize therapy so that they become effective faster and they stay out of the toxicity range if appropriate or if possible. And then understanding sort of the benefits, the limitations, and all of that are really important to making sure you're going to make rational decisions based off of those levels. And again, this is a common error you're going to see with a lot of providers. You yourselves might do this inappropriately in some cases here until you get a good handle on how to look at those levels, what they mean in conjunction with all the other kind of clinical things going on with the patient there. So if you have any questions, please put them up in the chat. Otherwise, I'm going to get moving on into the next section here, our last one. And so this is where we're going to be talking about designing dosing regimens. So this is kind of pulling everything together a little bit. We're also going to talk about prescription writing in some more detail right before your assignments due. And talk about some controlled substances and things like that. So when you're prescribing, as with all things in medicine, hopefully you're going to be doing it with a rational approach. And basically, you guys are going to be the experts on diagnosis, right? You're going to be experts on doing the physical exam. You're going to be experts on getting the history, doing these special tests, doing all these things. You're going to come up with your tentative diagnosis, and from there, lots of different things can be can happen. Like that, maybe the patient needs surgery, maybe they need radiation. Frequently, though, you're going to find that medication is going to be indicated for many disease states. That's not to say that every single patient needs medication. Certainly not the case, but a lot of them do, and so frequently this requires a prescription from you, right? So, and again, when a patient's come to see you in the office, for instance, they want you to do something, right? So if they come in and they're feeling under the weather and they're, all snotty and they got a fever and they're feeling miserable and they come to see you and you go, it's a virus, go ahead and go home and, drink some chicken noodle soup and you'll be fine. They kind of feel like they're getting gypped a little bit. And so a lot of people, they expect to get some sort of prescription. That's just what they want. They feel like they're getting a disservice if they don't. And most of the time they do get something. About 2/3 of the time they're going to get medication prescribed to them. And so we want to make sure when we're doing this, we're not just doing it as a knee-jerk and saying, okay, well, everyone gets a Z-Pack. I know providers like that everyone's like, oh, everyone just gets a Z-Pack. They're coming in with a cold, yeah, they'll just get a Z-Pack. Not appropriate, right? We're going to see why that's not, especially next semester. But really, you want to make sure you're following sort of a stepwise approach when managing these patients here. So, step one, right? So you make your specific diagnosis. So again, as I mentioned, patients want you to do something, but that may not always be appropriate. So if you're writing a prescription to satisfy your patients, just to make your evals look better, just like I have to worry about how you guys are going to evaluate me. I don't just go ahead and make every test super easy for you and make sure I just give everyone hundreds, because I'd get great evals if that was the case. But that doesn't really do you a good service, right? So you're doing the same thing for your patients. And if you're just prescribing things inappropriately, like you're going to see there's unnecessary cost to the patient, which may be a big burden to them. You can see more antimicrobial resistance, for instance, making our drugs less effective. And then you can see more adverse drug reactions, right? So sometimes you can, the cure, so to speak, can be worse than the issue they had in the first place. But to decide if they need a drug or not, you have to make that first diagnosis. And so I'm going to walk you through an example of a patient with probable rheumatoid arthritis, right? And again, when you make that tentative diagnosis, it's good to be able to communicate with the patient why you think that is the case, right? So based off of physical exam findings, based off of laboratory findings, we think that you probably have RA, right? And it doesn't matter if you don't know a lot about RA at this point. We will learn more about it next semester for sure. But once you have considered the diagnosis, then you have to think about what's sort of the pathophysiology behind that. And this is why it's so important you guys have a good understanding of normal physiology, so that way you can understand what happens when things go wrong with the pathophysiology. And then based off of that, you can make better decisions about what kind of therapy is going to be most effective for your patient. So for in the case of RA, you need to have a good knowledge of the different inflammatory mediators that are going to be upregulated that's leading to this joint destruction that you see with RA. And it makes sense that if you know there's a lot of inflammation going on, well, maybe anti-inflammatories are going to be effective, right? So knowing the pathophys helps you to know what sort of drug options might be effective in these sort of situations. And again, provide them with information that's appropriate based on their sort of knowledge base, right? So again, if you're talking to like a 3-year-old, they're not going to get a whole lot of this stuff. If you're talking to an adult patient who doesn't have a whole lot of, say they're not past a high school education, you start talking about interleukin 6 and tumor necrosis factor, it's all going to be Greek to them. And so especially the tumor necrosis factor alpha, that actually is Greek. But you're going to see that in those instances there that you're going to go way over their head. So again, determining where their level is at and then meeting them there is one of the skills you're going to develop over time, especially on rotations and whatnot. And so there's a lot of resources online that can also help you depending on sort of the level that your patient is at. So you got your diagnosis, you explain to the patient, you sort of understand the pathophys of what's going on here, and then you select your therapeutic objective, right? And so based off of the pathophys, you can identify what sort of goals you want to shoot for. So in this case of RA, well, one, they're having acute pain, right? So I want to relieve that pain by reducing the inflammatory process. And then as a secondary goal, you may also want to make sure that you're halting the progression of the disease. We have two different goals, and this may require the use of two totally different classes of drugs here. The drugs that we use in order to manage goal 1 may be totally different than goal 2. Sometimes they can pull double duty. It's not always going to be the case though. And so then you select the drug of choice. And so you can go and see based on the goals you've identified how we're going to be managing those. Do each of them require a different drug? Can I get multiple goals accounted for by using one drug? What's going on here? And then not only that, you may know what the perfect drug is, but it may not be perfect for your patient. So you look at the age of the patient, what other disease states they have, what other meds they're taking potentially. And so in the case of RA, using anti-inflammatories is sort of the gold standard for managing that pain they're experiencing and the inflammation. Well, do they have a history of not being able to tolerate things like aspirin? Do they have a history of GI ulcers, maybe that have been caused by NSAIDs? That may preclude me from using certain drugs, right? Does the patient have insurance, and can they even afford some of the medications I'm thinking about using here? So the RA, some of the drugs we use to arrest the progression of disease are engineered monoclonal antibodies that cost thousands and thousands of dollars. If the patient can't afford that, then they're obviously not going to take it. And then think about compliance things like, can I get away with once daily dosing? Is that really important? Is there ways to get combination drugs on board so that way I can improve compliance, especially for older patients? And then you're going to be determining the appropriate dosing regimen. So you've selected your drugs, you know what's going to be appropriate here, and then you're selecting, well, what kind of regimen is going to be most appropriate based on the kinetics of the drug and based on how my patient's kinetics are going to interact with that. So, do they have organ impairment? Do I need to change the frequency or the dose they're going to get? And then what will the patient actually tolerate? Are they willing to take a drug 3 times a day? Or are they going to be able to keep up with that, even though that's the best means of dosing the drug for them? Or are there ways we can get around that, like using extended release products or something like that? And so then you're going to devise a plan for monitoring the action. So you initiate the drug therapy, but you also got to know how you're going to monitor for that. So how do you know if the drug's being effective? How do you know what sort of side effects you're going to be looking for? What should indicate change of that therapy, whether it be a change of the dose, change of the frequency, or change of the drug altogether, right? And be able to describe that for the patient so that they know what you're also looking for as well. Because again, you're not going to be with them 24 hours a day. They need to be able to kind of report back to you. And so you should be able to describe to them what sort of drug effects you're looking for. You should experience, decrease in inflammation. Your joints should feel better when you're on these medications here. And any laboratory testing may go along with that, whether you need to do therapeutic drug monitoring or not, right? And, explain the rationale for prescribed duration of use too. Like if it's a medication they're going to take for the rest of their life, explain why that is. Some people feel like they take an antihypertensive drug, they get their blood pressure under control, and they're like, okay, I'm good to go. I can stop taking this. Not realizing this may be a chronic issue for the rest of their lives. Or they're taking an antibiotic and they feel better after 3 or 4 days, even though you prescribe them for 10 days, and then there's a failure of therapy. They don't eradicate the infection. It comes back, or it's resistant the next time. And then what would constitute change in therapy, right? So for instance, if I put a patient onto an NSAID, you need to let them know, hey, if you start to experience, hematemesis, if you start to vomit blood, right? Because they're not going to understand hematemesis in some instances. Or if you have dark, tarry stool, right? There could be evidence of GI bleeds that would prompt an immediate discontinuation of the drug, right? These are the things you have to educate them on to let them know what to look for, because they may not know what's normal, what's not normal with this stuff. And then you plan your program of education for them, right? And find ways to make it specific for your patient. So think about things like age barriers, language barriers in a lot of cases here. Like we deal with, especially in Orlando, a large number of patients who don't speak English, right? They speak Spanish exclusively. And so if you're not brushed up on your medical Spanish, like many people aren't, then that's going to be a barrier. So how do you get around that? Do you have translation services available? Do you have staff members who can help you out with that sort of thing there? And then educational barriers, like are they going to understand what you're telling them? If you're using especially a lot of medical jargon they don't understand, frequently patients don't want to admit that they don't understand what you're talking about. So you could be yapping at them for an hour straight and they're just going and they're getting none of that. Experience that with students all the time. And so sometimes I have to take a step back to be like, wait a second, like are we even on the same page here? And frequently it takes that to kind of stop and say, okay, let's kind of go back to square one here. So utilize the education materials when you have the opportunity to. So like pictures, they say a picture's worth 1,000 words. That can certainly help you out quite a bit. So here's a drug called Diastat. Diastat, and sorry it's a little blurry, but this is a drug called diazepam, is the generic, and it is a drug used to treat seizures. But if you notice, it looks like kind of a syringe. This is not IV, this is a rectally administered medication. So this is an emergency medication used when patients develop seizures, and this will stop that, right? Basically kind of puts the brakes, kind of hits the emergency brake on the brain, and kind of shuts everything down for a moment to stop that seizure. And this is something, though, that the patient can't give themselves, because if they need it, then they're seizing, and that's not going to be appropriate. So someone else has to give it to them, right? And so we frequently would see this in the pediatric ER. Patient develops new onset seizures, and we're trying to explain to the parent, who is probably pretty freaked out by the fact their child has a new chronic illness they're dealing with, have this diagnosis, and they're probably not used to seeing their patient seizing, or their child seizing in front of them. It's going to be pretty distressing. And so now you're giving them this drug and saying, okay, here's what you do. You have to pull their pants down, make sure you go ahead and administer it rectally, and then you got to hold it in, and a lot of it can just go straight over their heads because they're so overwhelmed with all this stuff. So have patient education examples, have things you can send home with them, so that way they can read it and make sure they understand that stuff after the fact. Or make sure you do a teach back method where you tell them how to do the thing, and then they have to be able to explain it back to you to make sure they understand what you're talking about here. Because this is not a drug you want to be fumbling around with and not know how to use when your child is seizing in front of you. So you want to make sure the education is there. So it's just like an EpiPen, just like anything else that is used sort of more of like an emergency basis there. And don't assume other people are going to explain it for you, right? So you think, okay, well, I'm pretty busy, I don't have time to explain all this. The pharmacist will tell the patient there. Well, guess what? A lot of those pharmacists working at CVS and Walgreens are doing 300 plus scripts a day, and oftentimes they don't take the time. Either they can't, or they're not asked for that time to talk to the patient. I'm not sure if any of you have ever filled a prescription at a pharmacy, but you go up to the counter, you pick it up, and the pharmacy tech is like, hey, do you have any questions for the pharmacist? And you're like, no, even though you might have some. And a lot of people probably have some, but they look busy. I don't want to bother them. It's not worth asking about. That happens all the time, and so that they need to you as a contact person, you got the person right in front of you, take that time to actually explain it to them, because you might be that last person. And so you want to make sure that you're not going to be kind of that that breaking point in the system there. You want to make sure that you're taking the time to do it. So let's go through another example here. Let's see one that comes in all the time, especially if you're working in PDR, if you're working in urgent care or something like that. Let's say we have a 3-year-old who presents with left ear pain. They have a fever of 101.3, and they've got cough and runny nose. And you take out your handy otoscope and you look at that and you just say, wow, it's a pretty inflamed little tympanic membrane there. You have a pretty good idea. Your tentative diagnosis is you're going to say it's acute otitis media, right? Based off this tentative diagnosis, you already know a lot of stuff about this. You'll learn about this in your medicine courses next semester, but you'll learn that, okay, well, what are the chances of bacterial versus viral? you'll know what the likely etiology is based off of this, and that will help you to determine, okay, do we need antibiotics? Do we not? Is it just supportive care? What are we going to be doing about this? And so you consider the pathophysiologic implications of the diagnosis, right? So you say, okay, well, I know it's acute otitis media. I'm pretty sure. What are the most likely causes for this? Is it very likely that it's bacterial? Yeah, it probably is. Well, based off of that, you got to know which bacteria caused it. And this is going to be the whole first thing we're going to talk about next semester. But, what are the most likely bugs for a given infection? And this is going to directly determine what antibiotics are going to be most appropriate for your patient, right? And then this helps us to tailor the antibiotic therapy, because you're going to see if you're using inappropriate antibiotic, either using things that are, kind of equate antibiotics to, guns a lot of times. Not that I'm particularly into guns by any means, but, some drugs are like a little BB gun, some antibiotics, and some drugs are like a nuclear bomb. For acute otitis media, you probably don't need a nuclear bomb to treat that, right? And so by tailoring our antibiotic therapy based off of what the likely organisms are, that helps us to prevent resistance, right? And then you provide that information to the parents of the family saying, hey, it may not be a bacteria and it may be something resistant, but here's what I think is going to be most likely effective for your child. And you can find lots of resources online. You can direct parents to or patients to in order to educate themselves. Now, I know some people may not trust the CDC, government bad and all that, but this is a really good resource. There are many others online where they can go ahead and educate themselves. Because again, you may tell them all this stuff, but they may not hear a lot of it, as the case may be. So this is why you can direct them to resources they can look up later and make sure that they understand everything that you told them. So now we're going to select an objective for our patients here. And so one goal would be to eradicate the bacterial infection, right? So that makes pretty good sense. And so we can use appropriate antibacterial coverage, which I'll talk more about in a moment. But then you want to think about, like, what else is going on with the patient? Well, they're miserable and they got a fever and runny nose and all that. Is there anything I can do to manage the other sequelae of the disease? And so we can look at things like managing the inflammatory response. They have a fever, well, perhaps they need an antipyretic, for instance. Different goals are going to require different drugs in this particular instance. So then you select your drug of choice based off of your goals. And so you take into account things like the age of the patient, their organ function, maybe they have previous allergies, or maybe they've been on medications previously. So if I have a patient who comes in and they have their third bout of otitis media in the past year, that's very different than someone who's had it for the first time, because they've likely been on antibiotics previously, and that may lead me to choose a different type of antibiotic due to potential resistance. Or maybe they have a current medication that may interact with what is currently on their medication regimen list, right? Or they have an allergy that precludes me from using certain antibiotics. Again, use your resources to find what's going to be most appropriate. Well, what kind of resources do you have? Well, there's a lot of them that are out there, right? So you can look up things like Lexicomp through UpToDate. You can look at things like clinical pharmacology or micromatics. There's a million of them that are out there. You can look at things that are specific for your disease state. So if you want to look at things that are specific for infectious disease, there's books like the Sanford Guide, or there's the Red Book, which is aptly named a red book that just includes pediatric infectious disease topics. And you'll learn about this as you get more into these different topics here. These are just examples. But usually the best thing to do is to go back to the clinical practice guidelines. Are there guidelines out there that directly tell you, if you have this disease state, this is the drug you use, this is how you use it? It's pretty clear cut. And you always will have a much easier way of defending your actions if you can go back to say, well, the guidelines told me this is what I should do. You never want to have someone come and question your management of a patient, and they say, well, why'd you do that? And you're like, well, I just kind of felt like it. That's not a good excuse. You want to make sure you say, well, based on the guidelines, this was the most appropriate way to manage this patient. That's always going to be a very good answer, especially when you're on rotations and your preceptors are asking you why the heck you think of something. You say, well, the guidelines told me. So based off of that, you want to consider with your drugs, like, okay, well, how often is it given? What kind of dosage forms are available? Are there different concentrations out there? Are there drug shortages that may be preventing me from using one or the other? And how much does it cost? Does the patient have insurance coverage? Are there free antibiotic options that are out there? A lot of places like Walmart and Publix will have free antibiotic options. And you're like, well, why in the heck would they give away free antibiotics? Well, guess what? That kid's got a fever and a runny nose, and so you go to Walmart, put it in your script, and they say, oh, it's going to take 45 minutes. and say, okay, well, I'm already here. Might as well go pick up some Tylenol for the kid, and I need to get some milk while I'm here, and X, Y, and Z, and then you end up spending way more money on all that extra stuff that they make up their money no problem for the antibiotic. So, and then looking at things like the palatability of the medication, is it a flavor the patient's going to take, or are they going to spit it back out at you? Can they take tablets, or does it need to be a liquid? These are all things you're going to consider for your particular patient. So then you get to select an appropriate dosing regimen. So here is a screenshot from the AAP guidelines specifically for acute otitis media. And again, make sure the guidelines are for your specific type of patient or that particular disease state. That's why we used Infectious Disease Society of America, because this is an infectious disease thing. It's pediatric patients, so American Academy of Pediatrics, these are good spots to look. And again, you can Google it. You can just Google guidelines for acute otitis media, and it'll take you directly to this, right? Most of the time it's free and available, even if you don't have library resources available to you. So anyway, so this is a table they'll have in most guidelines where they basically will tell you, here's exactly the drug you use and here's how to dose it. So based off of different indicators, right? So if this is initial, immediate, or delayed treatment, then here's your recommended first line. Or if they can't receive that for whatever reason, so in this case here, penicillin allergy, they're going to get Septynir instead, right? And they even tell you, well, what if the patient fails therapy? What if it's 48 hours and their fever's still going and their ear still hurts? These are things that you can do to switch over in order to account for things like resistance or a therapy failure, right? And again, it's very straightforward. It tells you exactly how to do it. Another section will tell you how long to treat for and all of that. It's a very handy, and it makes it easier for you to say, okay, well, this is what the guidelines say. This is the best evidence available in order to manage that patient there, right? So you've got your dosing regimen done. Let's say in this case here, we can go ahead and use amoxicillin suspension. I'm just walking through how we come up with that script again. So 90 mg per kilo per day, divided twice daily. The suspension we have is 400 mg per 5 mLs. Now, if you look up amoxicillin, you're going to find there's a lot of concentrations, but typically for these little ones, in order to prevent you from wearing that medication or the parent having to wear it when the kid spits it back out, you want to go with something that's going to be more concentrated because that leads to less volume needing to be administered, right? The kid weighs 20 kilograms, and so how many mLs do they need per dose? It's the same thing you're doing on your prescription assignment, right? And again, amoxicillin is one of those drugs, but it's a different indication here. So kid weighs 20 kilograms, how many mLs do they need per dose, right? So you figure out what the total daily dose is going to be, or you figure out what the per dose amount's going to be, whichever one you want to do. In this case here, it's divided twice a day, so instead of using 90, I just use 45 instead here. So 45 mg per kilo per dose times the 20 kilograms. Kilograms cancel out, and they're getting 900 milligrams per dose. Then I'm going to go ahead and find out the per ml concentration for my drug. Just divide that straight out, so 80 milligrams per ml. That 900 milligrams per dose divided by the 80 milligrams per ml, milligrams cancel out, and so then I get 11.25 mLs per dose, right? So again, do I write this specifically on the script? You could. You'll find a lot of dosing syringes are not going to be calibrated to measure that necessarily. So, could you round it to, I'm just going to say 10 mLs. That's probably a little much. I would say if you're within 10% rounding, you generally are pretty good. So if you wanted to round this to like 11.2 or 11.3, most dosing syringes can do that, right? If you wanted to round it down to 11, that'd probably be pretty appropriate. 11 and a half, also fine. Within 10% generally is going to be good for most pediatric volume calculations in that standpoint. Is that a hold for every drug? No, but for like 90% of things, yeah, it's probably going to work fine. So then you're going to devise a plan for monitoring the actions and look for endpoints of therapy. So obviously you want the patient to feel better, right? But what other things might you be looking at? Like you might be looking at fever resolution and things like that. You want to let them know about adverse effects, especially ones that are normal and expected versus ones that may constitute changes in therapy, right? So if I'm giving someone an antibiotic and they get diarrhea, I'm not going to expect them to come back in just for that. That's not an emergency sort of symptom because it's so normal for that to happen for patients taking antibiotics. But if they start to complain that they can't breathe and they're getting itchy all over, that's another story, right? They could be having an allergic reaction to that. Or maybe they don't improve. You don't want them just to take the full 10 days or 7 days and wait till the very end of that and they haven't improved at all to come back. Let them know after 2 to 3 days if things are not improving, then yeah, you can come back or call us up or whatever the case may be. And then find ways to educate your patients, right? So making sure they have specific, things addressing the language that they speak. So if they're from South America, they come from Brazil, make sure you got something you can give them in Portuguese, right? And frequently you'll find a lot of these drug references will have education pamphlets and things like that available in a variety of languages. It can be quite useful, but generally Spanish and English are going to be the most common ones, at least here in Florida, you're going to run into for the most part. But again, we're in Orlando, so whenever travel can happen again, then we may be dealing with, patients from all over the world, right? And again, utilize the educational materials. Frequently, patients are not going to hear everything you're saying to them because all of a sudden they're thinking, oh, wow, my kid's got an ear infection. I had no idea, or whatever the case may be, and they may stop listening at a point. So that's generally how you do the therapeutic approach, the rational prescribing here. Let's talk about the prescription itself, which I've already gone over a little bit last week so that way you could do your assignment. But when I say prescription, basically it's any kind of written, verbal, electronic order that is needing to be fulfilled by somebody. So whether it is a radiology department, whether it's a lab, whether it's a pharmacist, whoever, right? So we get the scripts, we fulfill them based off of that. Who are the people typically prescribing? Well, it's usually physicians like MDs and DOs. You have your physician extenders or advanced practitioners or whatever the current in vogue terminology is. I always hated mid-level providers because, you guys provide high-level care, so why would you be a mid-level provider? But regardless, so PAs and nurse practitioners here, but even some people you may not think about, like podiatrists and optometrists and veterinarians, any of these could be writing medication prescriptions that could be then delivered over to the pharmacist to fulfill. So generally, when you're writing prescriptions, glad you appreciate that. It is quite true. You guys are integral to providing care, because if it was just having to rely just on docs, we'd be in severe shortage for sure. But regardless, so looking at state versus federal laws, you may find that there's going to be a difference here between the two. So again, when I'm talking here, I'm speaking mostly to practicing in Florida because I'm just going under that assumption that we're in Florida. So most of you probably will practice here. And so generally, if there is a conflict between these two, between say state and federal laws, you always want to go with whatever is more strict, right? So if something says you can only give a drug for 2 days and something says 5 days, if you go with whatever is more strict, you're going to be usually adhering to both laws, and so then you're in the clear. In general, if the state law does not address it, then follow whatever the federal law is for a certain thing. And again, there may be some rare exceptions to that, but that's generally the rule. So when you're looking at prescribing errors, I talk about this a lot because medication errors are such a common thing, and I want to talk about things that you can do to avoid this when you are out there and practicing. You may find this on rotations too, that your providers or your attendings are just telling you, hey, go ahead and write the script for this, and I'll sign it. So you as the student are writing prescriptions, so you want to make sure that they're legal, want to make sure they're free of errors and things like that, because that provider may just go ahead and sign it and not even look at it. That may sound crazy, but it is absolutely true. People may just take what you say or take what you do at face value and think, okay, this must be good, I'm going to go ahead and go with that, without even scrutinize it. I remember when I was on a pediatric intensive care unit rotation, I was a student still. And so we had a patient who required a dose of Lovenox, and Lovenox is an anticoagulant drug. And so if you dose it inappropriately, it's very easy to cause bleeding. And if you're not dosing it, at an effective level, then you can cause clots to form. So it's a narrow therapeutic index drug for sure. And so I remember there was a resident that was on rounds with us, and the attending said, okay, well, the patient needs some Lovenox, go and write for that. And so then the resident came up to me and they said, what's the right dose for Lovenox? And I said, okay, well, it's this. Again, I'm a student, I'm not a practicing pharmacist. And so, and then that resident went ahead and wrote that down verbatim, didn't look it up or anything, and handed it over to the nurse to fulfill, right? It's before electronic prescribing in that particular institution. And I was just like, oh my goodness, like he just wrote that down. He didn't even question it, didn't even think about that I'm a student at all. I should probably go double check that, make sure I was right. I was 95% sure I was right, but then I had to go back and double check, and sure enough I was. But you'll run into those situations where you're like, ooh, I better go check that out. And then if you're wrong, it stinks, to go back with your tail between your legs and have to correct them. But it is a lot better than potentially that patient getting the wrong dose. So you'll find yourself in that situation all the time as a student. People giving you way more power than what you think you're ready for, but it's going to happen. So anyway, so again, all prescriptions need to be legible. They need to be unambiguous. Everyone who reads that should be able to determine exactly what you meant and exactly what you want. No one should have to make any assumption when reading your script, because we all know what happens when you make assumptions, right? So mistakes can certainly happen when that happens. So looking at the law, and again, I know laws are always fun to read, but looking at prescription requirements, this is again the Florida statutes. This is generally what we follow here. Now, in terms of basic requirements, these are for non-controlled substances. So these are going to be for things not controlled by the DEA, and so I'll talk more about those in a little bit. So this is your general set of prescription drugs, blood pressure medications, and a lot of seizure meds and anti-infectives and all that kind of stuff. Usually follow this. So if it's written or typed, it has to be legible, right? So you can't write out your scripts in wingdings or anything like that. That'd be pretty bad for the provider or the people having to figure that out. You have to include the name of the practitioner. You have to include the name and the strength of the drug prescribed. So if you're writing for metformin, you need to include that it's a 500 milligram tablet. Or if you're writing for amoxicillin, it's the 400 per 5 concentration, right? If you don't include that, then we don't know if the quantity that you actually write for, it makes sense based off of that, right? So make sure that's there. You want to have the quantity of drug to dispense based off of that. So for instance, if I'm writing for something to take 1 tab daily and I don't put a duration on that, then it should be 30 tabs or 30 capsules, or whatever the dosage form is, in order to fulfill that. So that has to make sense based off of your directions for use, okay? So the directions, again, that's your take 2 mLs twice daily for 10 days, whatever the case may be. Those are your directions, and it has to be dated. Make sure the date you actually wrote it yourself, and then signed by the prescriber. And so this is something where you have to do it on the date issued and not pre-signing a bunch of scripts, right? There will be providers perhaps who will have a prescription pad in their pocket and they pre-sign a bunch of them. Well, someone could steal that, and someone could write for fraudulent scripts and all that. So that's no good. So make sure it's signed on the date that is actually issued there. And then can be called in or communicate electronically. So it doesn't have to be the actual paper being handed in by the patient. It could be called in or faxed in or any number of means of communication over to the pharmacy. Generally, if it's called in and you leave like a message for the script, then usually a pharmacist will be the one to actually write that down onto paper, and then that's the record that we keep for that. In terms of how long a prescription is good for, it is good for 1 year, right? So at most it's going to be 1 year. So if, for instance, if you were to write a script and you want the patient to take it forever, presumably, if you write that initial script, that is the first fill, right? Then say, for instance, you write for 11 refills. That means they'll get that first month based off of that script, and they can get 11 refills throughout the rest of the year. Now, you could write for 24 refills, but it doesn't matter. The script's going to expire at the end of that year. It's not going to do you any good. So if it's a chronic medication they're picking up every single month, then typically you'll have the initial fill, which is that initial script they hand in, plus the 11 refills. Okay, that's the most you can get out of that script. So you can find that multiple non-controlled medications can go on the same prescription. That's totally appropriate. In terms of controlled substances, so we can talk about that a little bit later, these have to be separated out, right? So you can't put a controlled substance and then a non-controlled substance on the same script. And then if it's a C2, which we'll talk about what that means in just a little bit, this has to be completely by themselves on their own individual script, because these are going to be the tightest control we have over these prescriptions. So as an example, and this kind of probably looks similar to what I have on the actual rubric that I provide for you guys, you can see here that all this information is here. There's some additional information included here that is not required by law, but is generally pretty good practice. So for instance, if you want to put the allergies on there, not required. I don't require it necessarily, but it is not a bad idea to include that, because again, we'll ask the patient when we come in and get that filled, but if there's a discrepancy there, or they forget a allergy or something like that, that can lead to problems here. So by putting no allergies, that is somewhat helpful. Make sure that communicates that to us, so if there's any discrepancy, right? But they have the date of birth for the patient, so that way if there's multiple people with the same name, you can delineate between the two of them. And again, these are like national databases at like CVS and Walgreens within that particular company. So like all the CVSs are linked together, all the Walgreens are linked together. Guess what? There's probably going to be multiple people with the same name. So having date of birth really helps us to make sure we got the right patient there. The date that is written, the name of the medication. Here you have the brand name in parentheses. This is not necessary. You should at least have the generic there at a bare minimum. Here's the strength, so 500 milligram tablets. here's the quantity, number 100, right? Then you take one daily for control of diabetes. So if you notice, the indication is not necessarily required, but it is also good to include, so that way we know why you're using it, and we can make sure that your instructions make sense for that indication there. So maybe dosing for diabetes might be a little different than if I had a female patient with PCOS, for instance. So by knowing that, we can make a distinction there between the two, make sure that what you're doing is appropriate, because again, we are acting as another check for you as a provider to make sure that everything is making sense. If not, then that's when we call you up and ask about changes and things like that. So, be careful here. Certain indications you may not want to be explicit about, because there could be some issues of patient privacy that could be violated if someone else found the script, right? So, for instance, if you were writing for medications for HIV, for instance, you wrote for HIV infection, that may be problematic if someone's family member found that and didn't know that they had HIV, because there's, unfortunately, a pretty big stigma against that disease. Or if it was, say, for instance, for an STI, sexually transmitted infection, and their spouse found it and it said for chlamydia, and they're like, well, wait a second, how'd you get chlamydia, right? So for that reason, sometimes you can be a little more vague about it. You can say, for infection, for viral infection, or something like that, and that helps to get around some of that. But for diabetes, not a huge stigma against that, so that's totally appropriate to write that on there. So you'll kind of get a feel for that, and every provider will have a little bit different sensitivity for that. So that's just something to keep in mind. And then, of course, the sign at the bottom, there's your refills, and that's a pretty good script. Most of this will have pre-filled out for you depending on where you work at. For my prescription assignments, I'm having you actually write this out, so that way you can get a feel for all the things that are required on that particular script. So common errors that occur here is typically related to omission of information. So if you say things like resume pre-op meds, like all of them, did you just mean some of them? It's ambiguous when you say things like that. Continue present IV fluids. Okay, well, which one specifically, right? Maybe something's changed. You may want that to change as well, but you can't really tell based off of this. So you want to be really specific when you're making your orders here, right? So make sure that it's not ambiguous. You want to make sure that everyone understands what you're saying. So David's asking, in terms of writing scripts, what should be indicators for including refills? Didn't seem like we needed them in the assignment, but was wondering. That's a good point, right? So when I was giving you that assignment, that was intentional to avoid refills, because I wanted you more to get the actual process down. In the future, though, you may want to include some refills, right? So if it's a condition that is not going to resolve with that one script, then you may need to continue it, right? So if it's like blood pressure medication, then I always get questions from students. They're like, well, how many refills should I put? Well, what do you think, right? And I'm always and some people are less than satisfied with that sort of answer, but this is where I'm trying to get you to sort of start thinking about these things in a safe environment where you can't really make a mistake, right? Where you're not going to harm anyone or cause any inconvenience for someone. So, if it's something that is going to be a chronic problem, then yeah, you're going to want to probably include refills there, right? If it's something that's like an acute infection, then yeah, they don't need that, right? But what if that gout patient had recurrent gouty attacks, right? You may want to give them refills so that way the next time they don't have to come back in and see you necessarily. If that, meloxicam worked really well for them and they're going to have recurrent attacks, then maybe give them some refills. That way, in this case, you don't have to, because maybe it's a new onset sort of thing and you're not really sure. Sometimes you provide a limited number of refills because you want that patient to come back in and see you, right? So if you were to write for a new medication and you give them 11 refills, you're not going to probably see them again for another year, right? Even if you tell them, hey, I want you to come back in, they don't really have a reason to necessarily, because they're getting their meds. And so if you're looking for efficacy, if you're looking for, new labs or whatever the case may be, so sometimes if you want them to come back in sooner, you may do limited refills. So I want to see you in 3 months, so you only give 2 refills on a script, right? So as most things in medicine, the answer is it depends, on the situation. So not indicating long versus short acting meds can be problematic, because the dosing can be quite different between these two if it's available for them. And then just writing as needed without indications for what constitutes need, right? So if you write, take this medication as needed, but for what, right? One, the patient needs to know what to take it for. It may not always be readily apparent. And then also that way it helps the people who are dispensing to know as well what's appropriate. So David's saying, in regards to volumes like suspensions, do we include a little extra? The dosing doesn't, or if it doesn't use all of the dispense volume across prescribing time frame, EX liquid suspension. Just for our purposes, just write what is needed for that script. Like, don't worry about adding extra. Don't worry about what the bottle size is necessarily. Just write what is needed for that patient, and then the pharmacy will figure it out, right? What goes into that usually depends on how good the drug lasts for, like stability issues. So, for instance, most antibiotics come as a dry powder that we have to reconstitute, and most of the time they have a limited stability, like 10 days, 14 days. So usually we'll give them the whole bottle regardless in order to fulfill the script. So you guys don't worry about that. Just write what is needed based off of your instructions. Okay, so keep that one simple for you. So again, poor prescription writing is quite common even nowadays. You may think, well, everything's done via computer now. Like, who's actually writing scripts? You will find that a lot of your patient, or a lot of your providers who are clinic based, may still do a lot of handwritten scripts here. And so you're like, well, why do I have to do this, for these assignments? This is so archaic, but it is what it is, right? So you're still going to find this out there, and a lot of providers still do this, especially the old school providers. So make sure that you are not writing like this. Make sure it is legible, right? So here's some prescribing errors. These are things I'm definitely going to count off on if I see this on your scripts, because it is common, more common you might think, and it also can lead to some pretty significant errors here. So making sure you're writing your numbers out effectively and appropriately. So misplaced decimals is the one I always catch some students on. So if you have a number less than 1, right, so if like 0.5, you need to include that leading 0, right? Why do we do that? Well, because if someone looked at 0.1 and they couldn't really tell if that was a smudge or that was a real decimal point, they could misread that as 1, right? The 10-fold overdose, which can be deadly potentially. So if you have anything less than 1, at least for your prescriptions, write 0.1, 0.5, whatever the case may be. And again, I know a lot of you may be used to like undergrad, and when you're dealing with a lot of science heavy courses, and you know that like decimal places are important because it tells you how exact the reading is. This is not that, right? We are just trying to communicate exactly how much of a drug a patient needs here. So always have a preceding 0 for anything less than 1, and then don't include unnecessary zeros after the decimal. So if something is just 1, just write 1. Don't write 1.0, because again, that could be misread as 10. We're trying to make this as error proof as possible, but that's never going to be possible, right? Error resistant is more what we should be saying here. And then and again, you have that list of things I put on as like non-approved abbreviations on the prescription assignment, but never write U if it's units, because again, that can be misread as a 0 potentially. So it looks clear on here because this is type, but if you can imagine writing it, then it could be misconstrued. So 10 U of insulin could be misread as 100 units instead of 10, and then that could lead to a certain overdose and potential death for that patient from hypoglycemia. So just write out units. If something is in international units, you don't have to write international, just write units, right? Just write units, and that's fine enough for my purposes here. And again, I'm teaching you sort of like the most strict way of doing things. Reason being is that if you at least get it as strict as possible now, then you'll have some good habits set up to when you go out there and are actually practicing. But you'll find that your preceptors and things may do things differently than how I'm telling you. And that may be okay. Some of it may not be, but a lot of it is bad habits they picked up over the years. And so I at least want you to see like what the absolute right way to do things is. So that way, if you see some things maybe like, or kind of cutting corners a little bit, or little efficiencies, you can at least know, okay, well, at least I learned what the most effective, the safest way to do it is. Maybe I will not do these things in the future, right? So it is what it is. Micrograms can frequently be misread when it's abbreviated this way as milligrams, and so that's going to be 1,000-fold overdose. So again, not great. So just use mcg instead. Less likely to be confused. Harder to read mcg as milligrams and writing micrograms like that. QD is something we never ever use. Just write out daily. You can write Q daily, once a day, whatever the case may be, because it can be mixed up with QID, which is 4 times a day instead of 1, right? So just write out daily. And then this is kind of an older example here, but not writing out the full drug names can be problematic. So for instance, the drug morphine sulfate used to be abbreviated MSO4 all the time, and that would be confused with MgSO4, which is magnesium sulfate, right? And so if your patient needs morphine, you give them magnesium, they're not going to be too happy with you, and vice versa. That could lead to some big issues. So make sure that you are writing out the full drug name so we know specifically what you mean. Assume the person reading it your script is going to be the most incompetent person ever, so that way you can make sure that you're writing it as error proof as possible, right? Some other things that you may run into is if you not include the strength and the dosage form, that can lead to errors because there could be some big differences there. So for instance, in that amoxicillin example, I talked about 400 milligram per 5 ml concentration. There's a lot of other concentrations out there, as you may know, when you looked on your prescription assignment. So if you don't write that down and then someone makes an assumption about what you meant, that could lead to some big errors in dosing, especially if we don't know what the indication is. And we're just saying, okay, well, I guess this may be an appropriate dose. I don't really know. Ideally that person should be calling you back, but some people may not do that, right? Not everyone's a competent practitioner. And then don't ever write in teaspoons or tablespoons. Just keep it in mLs only, and that way that can be the exact measurement possible, most exact measurement. Make sure you include the quantity of drug and make sure it makes sense based off of what you're prescribing, right? So again, if you are writing for something that's only 7 days and you're getting 2 tabs a day, well, 2 times 7, the quantity should be 14. If there's a discrepancy there, we're going to call you up. And mainly I'm telling you all this so that way you prevent all these annoying pharmacists from calling you up. You're going to get 2 years of me, and so, or I guess just a full year of me, and that's going to be enough pharmacist interaction for a lifetime. So basically I'm just trying to prevent you from having to have all these other people call you up and annoy you, right? Anyway, and then if you want something that is brand name specifically, you have to write DAW, which stands for dispense as written. Some script pads you'll see have a little box you can check off there for dispense as written. Us as pharmacists, we have a responsibility to make sure patients get the most cost-effective therapy possible, and so we will automatically sub out brand names for generics. So if you just wrote the brand name, so if you just said glucophage instead of metformin, we would sub it out for just generic metformin because it's cheaper and it's going to work the same because they're bioequivalent. There's rare instances where that's not possible if you wrote the brand name, but that's not worth us even talking about here. It's so rare. So make sure that if you want dispenses written, if you want the brand name, that's what you write there, right? So, and again, here's some other abbreviations you should avoid whenever possible because they could be misread. I'm not going to go through each one of these, but I kind of hit on some of the major salient ones in the previous slides. So other things you run into, take as directed is a common one. Patient or providers will write on their scripts there. This is appropriate if you have something that is very explicit. So for instance, here is a methylprednisolone dose pack where it basically will tell you each and every single instruction. And this would be hard to write out on a full script because there's so many of them. So that you could write, take as directed, and that may be appropriate. Or like a Z-Pack, take as directed. That's why they write so many Z-Packs, because it's easy to prescribe. But I'm not going to give you that luxury while we're here in school, so I'm going to make sure that you cannot do that. So if you ever write take as directed on one of my script assignments, you're probably going to get pretty heavily deducted points there, so don't do that. Make sure you actually write out specifically how you want them to take it, right? Now, some other areas you run into, and any of you have like ER experience, you'll probably have run into some of these. But drugs with different forms, like you can't necessarily assume that everyone's on the same wavelength in terms of communication, right? No one has ESPN, unfortunately, in the hospital setting or outside of that, and so we got to make sure that everyone can communicate because no one's going to be able to read your mind. So if you ever hear, say for instance, you have a cardiac arrest going on right in front of you, patient's getting CPR, you say give them an amp of calcium, stat. Well, what are you talking about? Because most places in your code carts and your crash carts, you're going to have 2 different forms of calcium. And what's really confusing too is one's calcium gluconate, one's calcium chloride. They're both a 10% solution. They're both 10 ml vial, and they're both 1 gram of the drug. So you're like, okay, well, they must be interchangeable, right? Well, no, because if you look at it, calcium chloride has 3 times the elemental calcium as calcium gluconate. So if I give someone calcium gluconate when the provider meant calcium chloride, that's a third of the dose I'm really giving them, basically. Or vice versa, I can give them a 3-fold overdose as compared to what the provider wanted, right? So make sure you're being explicit. I want 1 gram of calcium chloride for this patient, or I want 2 grams of calcium gluconate. That way you eliminate any of that ambiguity there. Or give them an amp of bicarb. Again, most of the time we're not even dealing with amps anymore. Amp is short for amplifier. Also ampule. The ampules are basically a glass sort of vial that you have to crack the top off of. and we don't use those too frequently anymore because of concerns with cutting yourself and things like that. These are all vials we're using here. So AMP is kind of itself sort of an anachronism that is not super appropriate, but people say it anyway because they hear it on TV when they're growing up and they sound pretty cool and they're saying it, so that's why they do that. But if say give an AMP of bicarb, well, we have two main types we carry. So we have the adult sort and we have the one that says infant on it, but one is 50 milliequivalents because it's a 50 ml syringe at 1 milliequivalent per ml versus this one is only 5 ml, or sorry, 10 ml it looks like, and it's a half milliequivalent per ml, so it's only 5. So 5 versus 50 is a tenfold difference in dose here. So if you're not explicit about which one the patient should get or how much they should get, again, you can find some errors there. And it may seem obvious, but when you're in the middle of a cardiac arrest or something equally sort of emergent, you may find that people get nervous, people get anxious, people make really obvious mistakes. And you're like, well, how in the heck could you ever do that? But unless you're in the heat of the moment, you may not really know what that patient or what that person's really experiencing. Be really specific with your units, right? So someone yells out, start the patient on 20 of dopamine stat. 20 of what? Like, do you mean like milligrams per hour, mics per kilo per minute, 20 ducks? Like, what are you talking about, right? So be explicit here. And this is frequently why I do what we call callback communication or closed loop communication. So that way if someone says something like, well, start 20 of dopamine on the patient, I'll say, okay, so you want 20 micrograms per kilogram per minute of dopamine IV now? And they'll say, oh, no, that's not what I meant this other thing. That helps us to, and it sounds silly because it sounds like we're just repeating the same thing to each other. It sounds like we're a bunch of parrots, but it helps to identify those miscommunications and clear that up. So ideally, the provider would be very explicit, and you would say, I want 20 mics per kilo per minute of dopamine IV now, and I will call that back, and you'd say, yeah, that is correct, And so communication is critical, especially in these really emergent sort of situations there, right? I've had cases where entire bottles of a drug have been infused into a patient in the course of minutes because someone screwed up and they thought they should have been getting milligrams per hour and they accidentally programmed it in as mics per kilo per minute or something like that, so it happens. It may sound like, well, who in the heck would ever do this? It happens. Other things include inappropriate drug prescription, so being unaware of a contraindication a patient may have to a specific drug or certain interactions may happen here. If you don't have the full medication list, that can be an issue too, or if there's any kind of like physiochemical incompatibilities between other medications on their list. And even some disease state interactions too, right? If you're writing a med that worsens a patient's glucose levels, deals with their inflammation, but it makes their glucose go up and they're diabetic, that can be a problem, right? So, when we talk about compliance here, I'm going to try to finish on time, but I may be a little, go over a little bit, so hopefully you'll forgive me on my last lecture here. But so when we're talking about compliance, this is also referred to as adherence. Why are patients like maybe not following your instructions? And so there's 4 kind of main reasons here, which I'm going to get into. And some of it could be, errors on the prescriber's part. Some of it may be errors on the patient's part. So for one, if the patient fails to even obtain the medication, a lot of this has to do with either cost, difficulty in getting the right medication. So especially if it's like a specialty product or something that has to be compounded special that is not commercially available, it could be difficult to even find a pharmacy that will make it for them. Or if all the pharmacies in the area are closed during a certain time of day, or if they even have a lack of perception of need for the medication. These are common things you'll see. And so I'll never forget when I was interning as a student. I was like between my first and second year of pharmacy school. So I didn't really know a lot about the world at the time. And I had a guy come up to the CVS counter and just got back from the ER, and he has 2 scripts. He has one for amoxicillin or something for a tooth infection, and he has another one for Percocet. And so he goes, oh, just fill the Percocet. And I'm like, well, don't you have this infection? Shouldn't you need antibiotics for it? And he's like, no, I'm good. I just want the Percocet. So again, this is a case where a patient maybe have fraudulently going to the ER trying to get pain medication and was not filling the other antibiotic. Did he have an actual indication for it? Who could say? But he wasn't going to be able to treat that because he never got it filled. So sometimes patients are trying to play the game a little bit. Sometimes it could just be due to the fact they can't afford it, right? If they're not taking it as prescribed, either they're taking the wrong dose or the wrong frequency. Maybe they misunderstood what you meant, right? So you could say, well, take 2 tablets by mouth twice daily. Okay, so maybe they know, okay, I'm taking 2 tablets in the morning, 2 at night. Maybe they understand you and think, okay, I'm taking 2 tablets a day, so I'm going to do 1 in the morning, 1 at night. So you can see how this can be mistaken, right? Or they're taking things via the wrong route, or they have improper technique of administration, right? They have an inhaler and they weren't educated on how to use it appropriately. So again, this is why I talk about that teach back method, to where you tell someone, here's how you do this, and then you have them teach it back to you to make sure that they have a good understanding of how they should be doing this, right? Sometimes patients will prematurely discontinue a med. So if they feel like the med's no longer needed, so for instance, if you write for a 7-day course of antibiotics and they feel better after 3 days, they're say, well, I don't need it. I'm going to keep the extra around for, a rainy day or something. Not great, right? You need to make sure you explain to them why it's important to complete the entire course based on your instructions there, right? Or if a patient finishes the bottle and think, all right, I'm good to go. I took, a month of that, hypertension med. I must be good to go, not realizing there's 11 refills there waiting for them, to come back to. So that's one reason. Another could be they have a lack of perceived benefit. So this comes up a lot with a lot of behavioral health medications, like things like antidepressants. Antidepressants take a couple of weeks to really kick in. So if you're depressed and you're taking this thing that's supposed to make you feel better, it's been 2 weeks and you don't feel any better at all, then you may discontinue it prematurely, right? Or if they don't really perceive that it's going to be a chronic nature of the disease state, right? So if they are, taking it, they feel better all of a sudden, and they're like, okay, I'm not depressed anymore, I can stop taking it, and then they rebound and go right back into another bout of depression. That's unfortunately more common than you might think. And then patients can take things inappropriately, right? They may be sharing medications with others. They take someone else's medications, maybe as a cost-saving means, or they could be abusing it specifically, right? So if it's a medication that they use for ADHD, but they got a big test to study for tomorrow, so they take an extra dose. That's medication abuse, right? If they're taking extra pain medication because it makes them feel good, that's medication abuse, right? So there's a lot of reasons why people may be taking this inappropriately that is sort of intentional on their own part. So that kind of gets into controlled substances here. So what is a controlled substance? Well, this is a drug with a perceived potential for abuse, right? So abuse, what that means is that they may use it for certain non-therapeutic purposes, and it carries along with that a risk for psychological and or physical dependence, right? So when we talk about dependence, it means they have a physiological or psychological need to continue that drug, and that can lead to addiction, right? As when we get to a lot of substance use disorders. And so basically, in order to prescribe these, you have to have a DEA number on the script. And again, Florida is pretty slow on the uptake for a lot of these laws. And so, within the past few years, it's now possible for PAs to prescribe controlled substances, which is great. But again, in order to do that, you have to be registered with the DEA because of the Controlled Drug Act has sort of set up all of these rules here. Now, there's 5 different schedules, and sort of go down from the highest control being with Schedule 1 substances all the way down to the least amount of control with Schedule 5. And in my mind, you can sort of break them down in terms of how we're going to think about them as Schedule 1 being one category, Schedule 2 being its own category, and then you can kind of lump 3 through 5 together. And we'll see why that is in just a little bit in terms of how we can, how they're going to be controlled in terms of scripts and things like that. So basically, Schedule 1 substances have the highest abuse potential, but they don't have any sort of acceptable medical use, right? So there's no reason why you should be using them in the normal course of taking care of patients, and so they are not available, right? So heroin, for instance, probably a pretty good analgesic, but it is not defined as having any acceptable medical use unless you're using like old-timey toothache medications back in the 1800s or something, but nowadays not acceptable, right? So you'll never have this available to you. It is illegal to have these federally. That's it. Schedule 2, on the other hand, though, does have a high abuse potential, high risk for dependence, but it does have a currently acceptable medical use, right? So we'll talk about some examples of C2 medications here, but this is the kind of the highest control that you may be prescribing as a PA. And then you have 3 through 5, which have sort of declining levels of risk for dependence as they go along. 3 will be more at risk for dependence than 5, but again, they kind of, in terms of control, they sort of get all lumped together in terms of how they're regulated. Okay. So what are some additional requirements you have to have in order to write for a controlled substance? So besides being signed up with the DEA, getting a DEA number, and certain education you have to do for that. Some other things you have to include on the script includes things like name and full address of the patient to make sure that it's actually that specific patient, or the owner of the animal. And you're like, well, why would an animal need a controlled substance? But there's certain indications, like you have a dog with like a seizure disorder, they may get a controlled substance for that, which we can talk about later. But and if it's an animal, you have to specify the species on there. So you have to say if it's a dog or cat or, I don't know, iguana, whatever the case may be. And then you want the full name and address of the prescribing practitioner along with the DEA. This will usually be included automatically in your on your scripts. It's usually pre-printed in a lot of cases there, so that shouldn't be a problem. And then when you're writing out the amount to dispense, you don't want to write just a number there, right? So if you're writing for the number 10, if you want to give out 10 tablets of something, if you write that, it's very easy for someone to come along and then write another 0 there and say, okay, well, now they're getting 100, right? They can doctor those scripts, so to speak. And so that's not great. And of course, if they wrote like this, you'd probably assume there was a toddler trying to write that anyway, so you wouldn't take that. But regardless, you have to write it out textually. So you have to say 10, T-E-N, spell it out, so that way it is more difficult to sort of adulter that script, right? That's one of the big things we worry about. In terms of other requirements, so for a C2, and again, because the C1 you're never going to be prescribing because it's not available to you because there's no acceptable medical uses, a C2 cannot be refilled, okay? But you can write up to a total of 90-day supply for it. And it has to be written on tamper-resistant paper, and I'll show you what that looks like in a moment. So what that means is that, especially, and this comes up most often for chronic C2 medications, so like for ADHD meds, a lot of those tend to be stimulants like amphetamines and things like that. And so, for instance, you had a kid who was going to school and you wanted to write for this. You could write for either one script for a 90-day supply, which most people would not do. What they do instead is they would write 3 separate scripts, and they would have do not fill until this date written on 2 of them. So then one they can fill initially, no problem, and they'll have another one that says do not fill until this date, and then another one that's do not fill until 1 month later. And so that way they get the full 90 days, but you're not writing for refills because that's not allowed via the law. And so they also cannot be transmitted over the phone, so you couldn't call this in. They have to actually have the paper in hand when they take it to the pharmacy. And there's some new rules regarding opioids. We'll talk more about these later in terms of pain management. That'll come up probably in the spring semester, if anything, but we'll talk more about that later. So there's some new rules regarding how often you can, or how much you can prescribe and things like that. So that's for C2s. C3s, 4s, and 5s, you can write for refills, but a maximum of 5 refills because these scripts are only good for 6 months. So non-controlled substances are good for a year. So you could write up to like 11 refills. Schedule 3, 4, and 5 are good for 6 months. So you can write up to like 5 refills. Schedule 2s, no refills. Okay, so pretty straightforward. Here's an example of counterfeit evident paper. So if you were to photocopy this, you see void all over it, and that would give us an idea that it was photocopied, and no one would ever fill that, hopefully, unless you had a really bad pharmacist, maybe. And these are made by a specific vendor, so it's very tightly regulated in terms of who's getting these scripts. And then, and again, they may not be transmitted electronically. There are some newer methods to try to do this safely and securely, but it is not worth talking about at this point because it's still pretty new. And again, it has to be hand signed by a provider. So with your other non-controlled substances, you can do the stamp, you can do electronic signatures, but for the C2s here, they have to be hand signed by the provider, right? So that's one thing you want to know with that. So just real quick, and again, we're not in class, so I can't really have a good call and answer sort of thing here. But in terms of like what schedules that things fall under, I want you to kind of think about this. So, things like morphine. Morphine's a pretty high abuse potential, right? And people abuse this for its analgesic and euphoric purposes. This is a C2 medication, right? So it has very tight controls on it in terms of prescriptions and things like that. How about cocaine? What do you think schedule cocaine is? And a lot of people would probably say schedule 1. There's no acceptable medical use for cocaine. You'd be wrong, though. It's actually a C2. Why is that? Well, cocaine is an anesthetic, so it can numb up an area if you're maybe doing some minor procedures. It can also cause vasoconstriction, so that helps to decrease bleeding to the site. So there's some ENT providers, ear, nose, and throat docs, who will actually use this for certain surgeries. And so even at Nemours, we carried cocaine for a short period of time until the docs who said they were going to use it never used it, and then we just got rid of it, expiring the stuff. Methamphetamine. Again, you would think, okay, there's no use for this stuff. It's crystal meth, but actually, no, it still falls under Schedule 2 because, again, we can use amphetamine derivatives and things like that as a use for ADHD most frequently, right? Now, if I put like MDMA or ecstasy on here, that would definitely be a Schedule 1 because there's no acceptable medical use for that. And then marijuana is kind of the interesting one out of the bunch here because there's many states that are decriminalizing it for recreational use. A lot of places have it for medical use. Florida is a specifically a medical use state. Even though that is the case, so federally speaking, it is still a Schedule 1 substance. And if you recall before, I said we got to follow whatever's most strict. But again, marijuana is kind of the oddball out here. So we'll talk more about that later when we talk about pain management. But just know this is still a Schedule 1 substance, federally speaking, but state to state, the government has allowed the states kind of do their own thing in terms of managing that. So this is, again, the oddball out. And then even in certain states, you may find that different states may control different drugs differently. So for instance, there's a muscle relaxant called carisoprodol, the brand name Soma. You have in many states where it's not a controlled substance at all, but in Florida, we have classified as a C4, so some limited abuse potential, mainly because we saw there's a certain amount of abuse happening with it in our residents, and so they decided to go ahead and make it a controlled substance to put more constraints on prescribing it. And then even some drugs can change schedule as time goes on. So for instance, tramadol is kind of a wimpy, kind of partial opioid agonist. It was unscheduled for the longest time, and so it was good for nurse practitioners and PAs because it gave you something a little bit stronger than an NSAID to prescribe for pain, for more moderate pain, but it was not controlled. But there's also a lot of abuse that happened with it for people who had ready access to it, and so it actually got bumped up to a C4. And then hydrocodone used to be like the #1 prescribed drug. Hydrocodone, acetaminophen on top 200 drug list was like always #1 because it was a C3 and you could write refills on it and things like that. But now it's a C2, got bumped up because all the abuse with it. And so now it's really curtailed its use in a lot of cases. So it's really limited now compared to what it used to be. So things may change over time. These lectures may become irrelevant, but that's why I go back and update them. But anyway, so that is it for this last section. This is the end of the test material. So do you guys have any questions that I can answer before the exam? Let me look at the sticky note too. Oh, got a bunch of questions on here. Wow. It's exciting. Okay. So someone said for the prescription assignment, do we include discontinue 2 or 3 days after resolution of clinical signs? You don't have to include that. I wrote there to take a 7-day regimen, so just keep it the 7 days. I'm not trying to confuse you guys at all on that sort of thing there. Let's see. I know we're supposed to include the concentration of amoxicillin, but do we also include the dosing regimen or just include the amount of mLs the patient is supposed to take? You don't have to include this, right? Because we can determine that based off of knowing the weight of the patient and knowing how much you're actually prescribing. So you do want to write, if it's 400 milligrams, you have to write 400 milligrams. Ideally, you can write down the mLs. That's if you don't have the mLs, I'm going to count off for that. But could you say take 5 mLs twice daily, and then put 5 mLs in parentheses, put 400 milligrams. That's fine. That gives us a way to double check the dose there, so that's totally fine. But you don't have to include the weight-based dosing. That is not required. Do you want us to use a 10% rule rounding on our pediatric prescription assignment? That's fine. I'm not going to count anyone off. If you put 11.25 mLs, I'm not going to count you off. But if you round it to 11.2 or 3, that's appropriate. Again, within 10% is reasonable. If it's more than that, I might count off. Let's see. So marijuana is Schedule 1, but is actually treated in Florida as Schedule 2, 3. It's actually scheduled, or it's managed a little bit differently because you can't go to a typical pharmacy and pick up marijuana. There are dispensaries, and so you have to have providers who are registered and licensed to prescribe marijuana, which PAs cannot do in the state of Florida. But you'll have a physician who will say, okay, this patient is authorized to get this much medical marijuana, and so they get what I call it a green card, where basically they can then go to dispensaries and pick it up. And so there's a certain amount they're allowed to get over a period of time. Then they have to go back to that provider and re-up on that. So kind of an oddball. So again, I'm not going to ask you on a test what schedule marijuana is because it is such a weird one out there. I just want to at least make you aware of that sort of thing. Is cocaine C2 because of its federal use in ENT? Should we study more classifications? You should be aware of what the difference is between those. I'm not going to ask you specifically on the test which one of these is a C2 medication there, because I was just kind of going over a cursory set of examples. But you should know the difference between a C2 and a C5, and a C1 and a C2 in terms of like how they're regulated in terms of the prescriptions you can write for it, right? So those are the things I'd want you to know with that. See, for the prescription assignment question 2, dispense quantity will always be more than 100 mLs for 10 days, and the available doses form 50, 75, 100. Also, when giving directions for suspension medication, does it need to be a whole number for the volume, or can I use mixed number? How do I prescribe this? So we kind of talked about all of this. So you can use decimal places because many dosing syringes will have the ability to do tenths of an ml, so that's totally fine. Your dispense quantity just needs to be based off of whatever you wrote for. So if it's 10 mLs for 10 days, then write for 100 mLs, right? That's 10 mLs once daily for 10 days, 100 mLs. Just write that, right? Don't get too complicated on there. You touch basically on the amount and kinds of calculation we can expect on the final exam. That's a good question. I wonder if I can bring that up. But I gotta make sure I don't accidentally show you guys the test. I'll probably post an example of questions I might ask. I don't recall off the top of my head what's on the exam because I set it up at the beginning of the semester. But a calculator will be provided for you if there are math problems on there, and it will be pretty straightforward stuff. So nothing as complicated as what was on the quiz in terms of like trying to figure out like drip rates and things like that. I'm not going to get that complicated. It may be, as complicated as doing a C0 equals dose over VD kind of thing. I'd give you the formula and you could figure it out based off of that. So it'd be like kind of one step sort of math problems there. Let's see. For the assignment, can we include additional info for the patient direction for use, take with meals or mix, or in practice is something you verbalize and we simply write take by mouth? You could just write take by mouth if there are specific instructions they need to do. So if you absolutely want them to take it with meals, you can include that, right? You don't have to include a lot of that extraneous stuff, though. If it's like you can take with or without meals, like if you don't really care, then you don't need to put that on there, right? You can just talk about that with the patient. But if something specific they need to do, then you want to include that on there. Will the final be 50% new material and 50% prior units? Roughly, it should be pretty equally spread out between these. There might be a little more heavy emphasis on the last couple of sections here, but it should be roughly equal for most of that. What's the difference between capsule and tablet? Is one more fast-acting or readily dissolves more than the other? Not necessarily. Usually capsules are sort of gelatin containers that include either powder or they include little pellets. Some people feel they may dissolve a little faster. It clinically doesn't really matter. It just depends on what the dosage form will tolerate in terms of stability and things like that. So clinically, it won't really matter so much for our purposes that we'll get into. All right, that's a lot of questions. What else can I answer for you guys? Let's see. Are there topics the students seem to have a hard time on grasping in regards to exam material? We've kind of hit most of them because we had a test on kinetic stuff already, so you guys should have a pretty good understanding of all of that. From the last set of material, not really. It's mostly just like conceptual stuff to get down. So the kinetics is really the hardest part of the class, I think. Getting down things like volume distribution and, maybe you have a little bit of trouble translating that when you're talking about pediatrics and geriatrics, but you should certainly know how those things differ between there. So that may be one sticking point for some of you, but that's what I would say with that. Any other questions? So you've been an awesome professor. Thank you. Looking forward to next semester. Oh, that's very nice of you. I'm not going to make the test any nicer because of that, but your kind words are appreciated. Thank you so much. And again, this is the first time I'm doing this for AHU, doing it distance like this. So like, make sure to give me some feedback. Let me know like what I could do to make this better or worse. I don't know what I could do to make it worse. That'd be kind of productive. But let me know what you liked, what you didn't like about the course, because I can course correct for next semester, right? So I can make some adjustments if need be. So just something to think about there. I do read every single one of those, and I take every single one of those to heart. So please let me know, because you got a whole nother year of me. So we want to make sure it's at least as educational and pleasurable as possible. So thank you for that. If not, I will talk to you guys next time. So have a great weekend and good luck on the test. I'll probably put out another announcement giving you some reminders or tips or something like that later on in the later on in the week. So I will see you later. It depends on the schedule, so you guys got to reach out to me and give me some times, and we will see what we can put together. So no promises, but if it works out, it works out. Yes, thank you all, and I will see you all next time.